Palliative care. The greatest dignity to be found in death is the dignity of the life that preceded it. Newland, 1993. Death has also been referred to as the last adventure of life. Palliative care is also referred to as end-of-life care or care of the dying. It is used in reference to an individual with a life-limiting illness which cannot be cured. Dying is an individual activity, and the person's needs should form the basis of the care delivered. Death is unique, and, as caregivers, we are used to death and its mechanics. It is important to remember that until death occurs, the person is still alive, and as caregivers, we must help the person and their families make the most of their remaining days, weeks, or hours. Dying is a time of tremendous change and uncertainty. We have to let go and face the unknown. Palliative care tries to ensure that the person has the highest quality of life, encompassing their psychological, emotional, physical, social, spiritual, religious, and cultural needs. This is also known as the whole person or holistic approach. Examples of these needs could be psychological or emotional, love, happiness, security, feeling safe, and hope. Physical, food, drink, personal care, mobility, sleep, and warmth. Social, relationships, interaction with others, being with someone, and not being alone. Spiritual, feeling wanted, having a purpose, and feeling at peace. Religious, close to one's God, reading holy books, attending places of worship. Cultural, customs, language, preferences, and ethnicity is respected. And sexual, aspects often ignored or considered unimportant. Couples need privacy. Palliative care affirms life. Dying is a normal process. It neither accelerates nor postpones death. It aims to provide relief from pain and other symptoms distressing to the individual. It offers support to the individual and their family during the person's illness. It enhances the quality of life, not the quantity. Communication. Whether communication between the person and the caregiver is verbal or non-verbal, it occurs during every encounter. When you enter a room to close the curtains or to give physical care, you encounter each other's presence. You are aware of each other. In caring for the dying person, there are vital verbal skills which need to be adopted. These can be divided into two parts: the language, the actual words used, and the paralanguage, how it is said, the tone of your voice, volume, pitch, clarity, and rate. Clear and precise language is very important at a time when clarity is needed. There are many behaviours which block or hinder communication with the dying person, and many aren't aware they are doing it. Types of behaviour are summarised as follows: normalising, automatic placatory comments. These convey a lack of understanding from the point of view of the person who is dying. For example, "Everyone feels frightened of dying" is a universal comment not specific to the person who is dying. False or premature reassurance. "You won't have any pain because we will give you painkillers." The person may not have experienced pain. Inappropriate advice. Imposing one's own opinions and solutions, as opposed to assisting the individual with exploration of ways to arrive at a decision. For example, "Well, I would if it were me," is not helpful. Leading questions. A question is asked in such a way as to predetermine a response from the person. For example, "You're looking fine. You must be feeling better." Closed questions, where answers can only be yes or no, leaving the person unable to express how they feel. For example, "Any problems with your sleep?" as opposed to "How are you sleeping?" Multiple questions, which can cause confusion. Passing the buck. For example, "Ask the doctor when you next see him." Asking for an explanation. The individual says, "I didn't sleep well last night," and you respond, "Why not?" Selective attention to cues. When questions are raised, a response is selective, addressing the physical rather than the emotional aspects. For example, "My pain has gone, but I'm feeling very low." And you respond, "I'm pleased that your pain has gone." Some people in the final stages of their life are aware of the significance of certain symptoms, such as increasing weakness, fatigue, and weight loss. This gives rise to the question, "Am I dying?" If this question is asked, you should find out the individual's perception. What makes them ask the question? Establish reasons. If the answer to the question is no, and the individual changes the subject, you should leave it there. If the answer is yes, you should confirm the person's thoughts. Pause and see if the individual raises any concerns. Address only those concerns. Answer realistically. Maintain hope, and assure them of continual care. The person may have asked their GP this question, or a palliative care nurse, or someone else that talks to them. When communicating with an individual, you should be sincere, friendly, firm and warm. Be positive and encouraging. Be honest. Demonstrate that you are listening. Use their name. Accept the person as he or she is, and try not to judge. Respect confidentiality. Respect the person, his or her level of comfortable social interaction, and the need for space and control. Ask only one question at a time, and keep language clear and simple. Ask for cooperation. Acknowledge strengths and skills and recognize achievements, but do not offer false praise. Maintain eye contact and remain at eye level. Standing over a person can be seen as threatening or authoritative. Touch or being with the person expresses feelings not verbally expressed. Don't fill silences with unnecessary chatter or music. There will be times when peace and quiet is needed. The person may wish to gather their thoughts. Demand, threaten, or force people. Overwhelm with friendliness. Overwhelm with choices. Treat people as children, or sit directly in front of the person as it is confrontational. Sit to the side or at an angle. Nutrition, hydration, and mouth care. End-of-life directives should be written very clearly and signed by relatives and the individual. Too many nurse managers are being questioned on account of manslaughter charges for people whose cause of death is dehydration, as it is seen as a neglect of care. A dying person may have a longer history, weeks or months, with gradual deterioration and increasing weakness, fatigue, weight loss, and drowsiness. Dehydration will cause a more rapid deterioration. The person may gradually start to refuse fluids and may not feel thirsty. When it becomes apparent that the individual's condition has reached the stage where there is no doubt that death is imminent, there is a need to redefine the goals of care to be provided and, at this stage, to implement the Liverpool pathway. Within the terminal phase, irreversible changes take place and death is inevitable. A degree of dehydration occurs in this phase, as muscles become weak and the person is unable to swallow. Good mouth care is essential and is usually all that is necessary to control distressing symptoms of thirst. The mouth is vital, as oral problems greatly impact on the quality of life for people. The mouth should therefore be kept moist and clean. Family can be involved in this aspect of care. Maintaining oral integrity. Regular twice-daily toothbrushing with a fluoride paste and soft brush. Increase frequency of oral care to 1 or 2 hourly. Dentures should be soaked in cleansing solutions overnight. Where toothbrushing is inappropriate or not possible, regular mouthwashes should be encouraged. Debris should be removed by mouthwashes by the person or small soft toothbrushes by the carer. A painful mouth. Oral care can be difficult in the presence of severe pain. A gel sachet used 3 times a day may be helpful for some people. Mouth care can include giving regular drinks whilst the person is able to swallow, assisting with brushing of teeth using a baby soft toothbrush. Frequent sips of water can be through a straw or on a teaspoon. Chips of ice. Pineapple pieces in juice, not syrup, to suck on. Avoid citrus foods and drinks as these are acidic. However, a small amount of lemon juice added to ice water stimulates natural saliva. Apply lip balms to keep lips moist and prevent cracking. And administer artificial saliva products or KY jelly. Signs of oral infection should be observed, such as thrush, and appropriate treatment given as prescribed by a practitioner. Any soreness can be reduced by rinsing the mouth with a prescribed local pain reliever or through medication. Dying people lose weight. This is due to many reasons. The disease itself is utilizing energy. The body may not be able to break down, metabolize food. The person may be nauseous or vomiting. Loss of sense of taste. Problems swallowing. Mouth sores or ulcers. Fatigue. Pain. The person may feel full after a few mouthfuls of food, and a person who is constipated lacks desire to eat. A balanced diet can, however, be encouraged. Offer their favourite foods. Offer meals when a person is relaxed, not tired or anxious. Offer a light diet, which is easily digested. Add cooked vegetables to soups to relieve constipation. Add whole grains to diet, as those who suffer with loss of appetite tend to prefer breads, biscuits and crackers which cause constipation. Offer steamed, pureed or stewed food which are easier to digest. Offer clear soups, soft drinks and nutritional supplements. Seek advice from a dietitian. A GP can prescribe drinks such as Fortisip. Make food attractive. Offer small meals, but often. Don't offer food which causes nausea, such as strong-smelling foods. Avoid greasy and spicy food. Families can feel rejected if the person refuses food. Or they may try to prolong life by trying to make the person eat when they really don't want to. Reassure them that, essentially, the person will be bedbound, weak, and drowsy for long periods of time, and they may be disorientated, with an increasing disinterest in food and fluids and what is happening around them. They would also find it increasingly difficult to swallow medications. Given this scenario, it is necessary to ensure that any interventions are appropriate, and those interventions which will not contribute to a peaceful death are withdrawn. All interventions should now be focused on comfort and safety. It is argued that dehydration can cause patient morbidity and hasten death, whilst others believe that artificial hydration is inappropriate. Limited available data suggests that hydration has no influence on the symptoms or survival when death is imminent. There is a lack of definitive research into the pros and cons of artificial hydration in those who are in the final stages of life. Until this is found, it is likely that medicine will be divided on this subject. Mobility and pressure area care. All individuals who are dying are at risk of skin breakdown as their condition deteriorates, combined with reduced mobility and possibly loss of appetite. The level of risk depends on the speed of the deterioration, the nature of the disease, and the level of existing debility. The use of appropriate pressure-relieving aids should help to diminish the possibility of pressure ulcers developing or exacerbation of existing ones. The dignity and comfort of the individual may be promoted by confining turning and moving to that which is absolutely essential, remembering that the wishes of the person you are looking after are paramount. They may not wish to be moved, as a risk assessment may indicate. Respiratory secretions. Those approaching the final stages of life are often unable to clear upper respiratory secretions. This is commonly known as the death rattle. This is a common symptom occurring in up to 92% of individuals who are dying. This can be reduced in some cases by positioning, although this is not suitable for all individuals, as it means moving the person to facilitate secretion drainage. Most people are unconscious when terminal secretions are present. The control of these secretions can be seen as a benefit in minimizing distress of relatives and carers. The main treatment may involve the administration of hyoscine injections, which should be given as soon as symptoms become apparent, as they will not control or reduce secretions that are well established. Dyspnea, breathlessness. As the person enters the terminal phase, it may not be possible to address all the causes of dyspnea. Treatment is therefore focused on reducing associated anxiety and making sure that the person remains comfortable. Many individuals fear they will die from suffocation and gasping for breath, which then increases levels of anxiety and subsequently their dyspnea. Ways to alleviate symptoms and anxiety: massage, relaxation therapy, medication to relax and take away fear, calming hand-holding, a calm atmosphere, cool air circulating or open windows, giving reassurance and advice, sitting them upright, raising the head of the bed, or placing pillows behind the back and neck to help expand lungs and increase air capacity. Avoid use of perfumes, as these can trigger coughing and cause breathlessness. Frequent periods of rest in between care interventions. Warm drinks. Removing tight clothing or bedding. Oxygen therapy. This has to be prescribed by a doctor. Or introducing a pet where appropriate can benefit and is known as pet therapy. Agitation or confusion. A person may feel sad as they approach death and realize that they are leaving familiar friends and family. Antidepressant drugs may be helpful and give an opportunity to talk. Sedation may be needed, but first, any easily reversible cause should be treated. As an example, urinary retention, which can cause severe agitation, will require catheterization. Other causes might be drug toxicity, anxiety or emotional distress, unexpressed fears, or forgiveness. The person may want to talk about things that have not been resolved. Confusion may be due to dementia or to complications in those with cancer. Individuals who are close to death may become agitated for no clear reason, a condition known as pre-terminal agitation. Confused people have lost their sense of reality and control over their lives. Ensure the environment has familiar things around them, such as family photos, a clock, and personal effects. The aim of the care team is to allow the patient to have a peaceful death with their symptoms well controlled. A syringe driver allows several drugs to be delivered to relieve symptoms such as pain, nausea, and anxiety. Death is approaching. Several common changes take place when death is approaching. Circulation slows down and body temperature will drop. There is a cooling of the skin, especially in the extremities such as arms and legs. Skin may feel clammy, and lips and skin will be pale. Weakness of muscles will cause bowel and bladder weakness. Loss of any remaining appetite. There may be a loss of any urine output. Movement decreases, the loss of ability to respond, and most of the time is spent asleep. Senses will fail. There could be the presence of pre-terminal agitation. Breathing becomes slow and laboured, with long pauses between breaths, Cheyne-Stokes respiration. Breathing may become coarse and bubble as secretions collect in the throat. Decreased levels of lucidity. The person may be heard talking to people who are deceased or others from their past. Muscles of the face relax and the nose is prominent. The pulse is weak and irregular. It is important to keep talking to the person once they lose consciousness, as they may be able to hear you, and although they cannot speak, they need to be reassured. Positive messages to show they are valued and promote a sense of worth and peace. Permission to let go of a life well lived. Care pathways. There are a number of names for predetermined guidelines of care that form a legal record. The Liverpool Integrated Care Pathway was established by the specialist palliative care team in the Royal Liverpool and Broad Green University Hospitals and the Marie Curie Centre, Liverpool. The aim was to establish a pathway for health professionals to follow in the last days or hours of a person's life. It is a person's right to be cared for how and where they wish, and with this in mind, the Advanced Care Planning, previously known as Preferred Place of Care, was created. It enables those who are dying to create a document containing information about their specific needs and wishes. This is updated or revised as they move through their care pathway as the illness progresses to the terminal stages. The Liverpool Care Pathway is not written in stone. It can be amended to suit specific care environments, such as care or nursing homes or other organisations. Pathways enable care organisations to provide effective care to those who are dying, meeting the wishes of the individual. Developing a deeper understanding about our approach to the care of people with life-threatening illnesses is one of the challenges that doctors, nurses and care workers are now beginning to address. Palliative care, the care of the dying and facing the mystery of death, is a skill that many healthcare workers have not had the opportunity to learn. Death is still considered by many to be the last taboo. We are reluctant to face our own fears about death and avoid discussing the subject with families and the people we care for. It is often the fear of dying rather than death itself that can be the barrier. The hospice movement has challenged the conventional hospital care provided for many patients and has set standards for enabling a person to experience a good quality of life and a dignified, pain-free and peaceful death, empowering and encouraging families to share in the end-of-life care of their loved one. The concept of the hospice at home movement is providing us with an opportunity to be involved in decisions about how and where our last weeks of life are spent. Caring for a dying person and their family can be a stressful, exhausting, and relentless experience. When someone dies, it is important for managers to allow their staff time to express their own grief and feelings, their own sense of loss. Emotional burnout is a professional hazard and can't be ignored or denied. Bereavement support should be available to relatives and carers alike. The National Gold Care Standards Framework and the Liverpool End-of-Life Care Pathway is highlighting best practice and offers a framework for a multidisciplinary approach to person-centered care combined with dignified medical and nursing practice. The care of a dying person and sharing their end-of-life journey can be a privilege and can enable nurses and care workers to provide the highest possible level of care in a peaceful and therapeutic environment. Death is not the extinguishing of the light, but the blowing out of the candle because the dawn has come. Rabindranath Tagore, Indian Sage.
One day when we were young, one beautiful morning in May, you told me you loved me when we were young one day.